my name is Christina Wai. I'm a surgical oncologist at Hartford Hospital. A lot of people probably don't really understand what a surgical oncologist is. Basically, I'm a cancer surgeon. And I'm going to go over a little bit. Some of the stuff I'll talk about may overlap with what Dr. Williamson talked about, but I'll kind of briefly talk about those ideas and then really focus on the surgical aspect of treatment for pancreatic cancer. So just briefly, I have no financial disclosures. And next slide. So every talk I do, I like putting up this slide. And I think the important thing to really remember when we talk about cancer care is it really is a team approach. There's so many aspects of cancer care, and it really takes a whole team of people to help diagnose the cancer, to treat the patients, and really to provide that comprehensive way to approach the cancer. And so in the center, I put the patient, and people like Dr. Williamson, gastroenterologists are involved. We have Marlene, one of our nurse navigator that's here, pathologists, physical therapists. They're all people that are involved with the care of cancer, and they really help make the success of a patient's outcome. They help to really make a patient's outcome very successful. So, we try not to forget any one of the components, and I'm just one piece of the bigger picture. All right. And so a little bit, before we go on to talk about the pancreas anatomy, I like to talk a little bit about the GI tract. What is the GI tract? When we think about when we're eating, essentially food goes through our mouth, and then it goes down through the esophagus, goes into the stomach, where there's acid which neutralizes a lot of the bacteria that we eat, and then that goes through the small intestines, which includes three parts: the duodenum, the jejunum, and the ileum. And then it goes through the colon, which is comprised of four different parts, from the left colon to the transverse colon, the right colon first, and then the transverse colon, the left colon, and then the sigmoid, and then finally through the rectum. Mm-hmm. And so along that route, the pancreas sits and it secretes enzymes and hormones that help to break down the food so that as it moves through the GI tract, we can absorb the nutrients that we need to until all the waste that we don't need ends up getting formed at the end, and the things get eliminated out of the body. And so what exactly is the pancreas? I think a lot of people have heard about it but don't know what it looks like, and I like Dr. Williamson's use of the description of flounder. So it looks like a little fish, and the word pancreas in Greek means pan, and creas, all flesh. So it's this fleshy organ that sits in the posterior part of the upper abdomen, and as I mentioned, it's part of the digestive tract. It's about 5 to 6 inches long. Sometimes people can have, if they've had a lot of pancreatitis, it can shrink down. It can be variable in size, but roughly about that size. And why people like Dr. Williamson can do endoscopic ultrasound is that it sits directly behind the stomach. And so when he puts down that probe, the ultrasound can see through the stomach and then have access to the pancreas. That allows him to do a lot of those procedures. Also, it sits right next to the duodenum, and I'll have more pictures of that later. And part of what makes pancreatic cancer so bad is that it's really close to all the important vessels in the body, all the vessels that supply blood to the intestines, and all the vessels that take blood back to the heart from the intestines. And so if you see in this picture, again, it's already minimized. There's a lot of bowel and other things sitting near there, but you see the stomach, and the pancreas is sitting right behind the stomach. And where you see the red and the blue, those are some of the major vessels that are running by there. And those vessels supply a lot of the organs within the GI tract. And then also you see the green is for the bile duct and the gallbladder. And so part of what also makes surgery really difficult is that it involves removing multiple organs and reconnecting multiple organs back up. And so we talked a little bit earlier, in the other talk about the different components, location of the cancers being in pancreatic head. So the pancreas, when we think about it, is divided up into 4 parts. So the head is near the, when you're looking at the picture on the left side of the picture, and then there's the neck, which is sort of the middle portion, the body, and then the tail. And there's a duct that's within the pancreatic duct that joins up with the bile duct, which ends into the opening of the first part of the small intestine called the duodenum. And so it's all that kind of junction of ducts and intestines that leads to some of the symptoms that develop when people have pancreatic cancer. All right, next slide. And so to touch a little bit upon what exactly the function of the pancreas is, I know Dr. Williamson mentioned it briefly, but I'll expand a little bit more. So there's two main functions. The endocrine function is actually the hormonal part of the pancreas, and then the exocrine part is the digestive enzymatic part to it. So in terms of the endocrine part, that has to deal with the insulin production and other things that are part of the hormonal function of the digestive tract. And so when we talk about cancers, you can get cancer in either portion of the pancreas, and that's what distinguishes between the neuroendocrine tumor that was mentioned earlier and the classic pancreas cancer, which is the adenocarcinoma. And really, from a surgical point of view, it doesn't matter which kind it came from, the treatment is the same. And the most important thing for us is where's the location of the cancer along the head, the body, and the tail. And so I think from a surgical point of view, that doesn't really change the operation, but the difference in treatment may be if people needed chemotherapy, each kind of cancer will respond a little bit differently to the different kinds of chemotherapies used. All right, so endocrine function, we talked about hormonal function includes insulin, which helps to regulate sugar in the body, glucose. So most people know about insulin from diabetes. And so if you have a tumor that overproduces insulin, then you get symptoms of low blood sugar and whatnot. If you have glucagon, which is sort of the reverse of does what insulin does, then that's what happens. And so it's just the function of the endocrine part of the pancreas. Somatostatin is also a hormone that the pancreas creates that helps to regulate all of the digestive enzymes. And finally, there's a pancreatic polypeptide hormone, which helps to regulate the pancreas's function itself. So it has this mechanism to turn on the release of hormones and digestive enzymes, and also helps to stop the release of all those things. The exocrine function, so that's the digestive enzyme part. So enzymes, essentially what enzymes are they break down nutrients into smaller components. And so so the two parts of the enzymatic function, well, it's actually not really enzymatic function, but pancreas also releases bicarbonate. That's basically to neutralize the acid in the stomach. We have acid in our stomach to kill off bacteria or other things that we may ingest, but then the acid is too caustic for the rest of the GI tract. So the pancreas makes bicarbonate, which neutralizes the acid so that the pH of the contents aren't that high, or I'm sorry, aren't that low. In terms of the enzymatic function, so there's three main things that the pancreas produces and helps to break down. So it makes lipase, which helps to digest fats that we consume. Proteases digest proteins, and amylase helps to digest carbohydrates. And so those are sort of the things that the pancreas may release from an enzymatic point of view. So one thing that I always like to talk about, when I talk about cancer, is letting people understand what is cancer. Because I think a lot of people think about cancer as something that invades the body, and they don't understand why they get cancer. I always tell people that being human puts you at risk of getting cancer. And really, cancer is just the abnormal, uncontrolled growth of normal cells. And so everybody has potential to get cancer. Because I've heard a lot of patients will tell me, well, no one in my family had cancer, why did I get cancer? And I said, that's one component of it, is that family history may affect your genetics, but just having cells and being human, you have a risk for having cancer. Because we don't really think about our bodies as being dynamic, but every day we have cells that grow, that divide, and that die off. And when some part of that process goes awry, that's when people develop cancers. So really, it's just the uncontrolled growth of normal cells. That's what cancers are, no matter which body part they come from. And so also what makes cancer so bad is that they can invade the normal organ, and then they can spread to other parts. So they destroy the healthy tissue, and then they can spread to other parts and destroy those other healthy organs. And so, again, I like to talk a little bit, more broadly first about cancer staging, because I think this is an important concept to understand. So the cancer staging system is the same for all kinds of cancer. So it's called the TNM staging, and it's composed of 3 different parts. And based on these 3 different components, that's how a cancer is staged. So this is the same for breast cancer, for colon cancer, for melanoma, and for pancreatic cancer. It's all based on these three components, and that determines the stage of cancer. And so cancer staging always starts from 1 and goes to 4. So people can't have a stage 5 cancer, they can't have anything above that. Sometimes we have stage 0 cancers, which are basically pre-invasive cancers, so they're not really technically cancers. And so the T component for staging is always it's some characteristics of the cancer. And so it may be based on the size of the cancer. So in the medical field, we always use centimeters and not inches. So it might be however big the cancer is, or it could be, if it's a colon cancer, what layer of the colon it's invaded. So it's some sort of characteristic about the cancer. And generally it's divided up into 4, T1, T2, T3, and T4. And then N is for nodal involvement. So lymph nodes are part of the immune system, and you have lymph nodes everywhere. My analogy when I talk to patients, lymph nodes are like the apple on an apple tree. So you have them throughout, and they're connected by lymphatics, which is like the branches of the tree. So you have lymphatics that travel throughout your body, and you have lymph nodes that are everywhere. I think most people know when they're sick, their glands get swollen. Those technically are your lymph nodes that get swollen. So you have lymph nodes in your neck, in your armpit region, in your intestines, you have them everywhere. And so cancers, they can get into the lymph node and they can spread through the lymphatics or the bloodstream and then deposit at a distant site. And so that's why cancers are so deadly, in that they can spread. And you don't always have to have a big cancer before it spread. I've seen cancers that are very small and they spread. I've seen big cancers that don't spread. So a lot of that mechanism of why certain cancers spread, no one really knows. There's some thought, that it's they call it the seed and soil hypothesis. So it's like when you're planting your garden, you throw a bunch of seeds. You have to have the right environment, the right seeds, the right nutrients, and then something will grow. So not every cancer spreads to every organ, and certain cancers actually only spread to certain organs. And so the last part of the staging system is the M, for metastasis. It means a spread from the originating organ to a different organ. So for example, pancreas cancer often will spread to the liver, or it may spread to the lung. And so a lot of people think, oh, well, if it goes to the liver, they have liver cancer. So that's sort of an incorrect way to describe it. If it spreads to the liver, it's still considered pancreatic cancer, but it's a metastatic pancreatic cancer. If it started in the liver, then it is a liver cancer. So that's sort of the distinguishing thing, is that where did it come from will determine your staging. And so automatically, if someone has metastasis, no matter if they have lymph nodes involved, no matter the size of the cancer, then they have stage 4 metastatic disease. And at that point, then we call it a systemic disease. So that's something that's an important concept in cancer is the cancer localized, meaning just staying in that organ in that region, or has it spread? And once it's spread, a lot of times surgery does not become part of the therapy. Because I try to explain to patients that surgery really is meant to remove the cancer, to cure the cancer, and to prevent it from spreading. But once it's spread, even though technically we may be able to do the operation, it may not benefit the patient because now it's gone somewhere else. And now it's in the system, it's in the bloodstream, it's in the lymphatics. So you might try to take out the cancer, but it's already circulating and it can deposit to other areas. So that's why generally when people have metastatic cancer, no matter what type, treatment is usually chemo, because chemo is giving medication into the bloodstream, which then can target the cancer. We talked a little bit earlier about statistics, and I'll just briefly go through this again. Pancreatic cancer is a very rare cancer, so there aren't that many cases. There's only about 46,000, and this is in comparison to other cancer types like lung cancer, breast cancer. There's probably about 200,000 cancer cases. So there's a lot of a difference in terms of the rate of it. So pancreatic cancer is quite rare. It's the 4th most common cause of cancer, and again, we said earlier, 7th to 8th decade of life is when most people have it. And so this is something that's published every year. They always say, what's the estimated new cases of cancer? And as you can see, it's divided between male and female. And pancreatic cancer is probably, as you see, number 9 on the female side, and it's not even really in the top 10 in men. So I just kind of added at the bottom, it's not even in the top 10 cancer. For women, it's number 9. And so again, it's very rare. Most of the cancers are prostate and breast cancer. And so that's why we talked earlier about research and funding. There's just so few cases. And so a lot of times there's not a lot of funding that goes towards pancreatic cancer research. Mm-hmm. But the thing, despite not being a very common cancer, it's a cancer that's very deadly. So when you look at it, it's the fourth leading cause of death for cancer. So there's a stark contrast in terms of the amount of people that have cancer and how many people die from that cancer. And so it is a very deadly cancer, whereas even though prostate and breast cancer are both very common, most people don't die from their cancer. If you see it, there's about 200,000 people that have breast cancer, but only 40,000 people die from their breast cancer. So that's roughly about 20% of the people. Whereas if you see here, there's 19,000 plus 20 is about 40-something thousand cases of people that die, then there's an incidence of 46,000. A majority of the people die from their pancreatic cancer. Yes.
So when the cancer spreads, when say it goes to the liver, and the liver is not the primary site, it's the pancreas.
Yes.
The cells in the liver, are they pancreatic cancer cells?
Correct. Yeah, and so I say that, I always tell people that there's different characteristics to cells, so even though they move. So I think Dr. Williams, I'm going to use him as an example. So when he spoke, you might have noticed he had a little bit of a southern accent. So even though he's from the south, when he moves up here, he still has that southern accent. So he still has features that make you realize he's probably not from New England. And so same thing with cancers. When it goes to other sites, it retains its characteristics and qualities so that when they look under the microscope, they can tell that it's a pancreatic cancer.
The reason why I'm bringing it up is because when they were genetically working at for malignant melanoma, and they treated a man down in Guilford, somewhere along the shoreline, and he was at the fourth stage, terminal stage.
Yeah.
And they genetically modified, he had a genetically modified treatment, and it relieved all his cancer cells.
Yeah.
So if we can do that, down the road with pancreatic and other cells, so it's almost like if you want a baby to die, you don't feed it.
Yeah.
And if you want it to grow, you feed it. So it's like finding a metabolic way and proteins and everything in that that's feeding it.
Yeah, there are certain, there are a lot of targeted therapies like that. So in a drug that's not really used in the pancreatic cancer, Avastin, it's an anti-angiogenesis chemotherapy. So it prevents blood vessels from growing. So there are different things, but there's not one size fit all, because something that might work in the setting of melanoma or colon cancer just doesn't work. And there's just something about the tumor characteristics that make it not work. And so even within melanoma, some of the targeted therapies you're talking about, if that cancer does not have that mutation, then it's not sensitive to those chemotherapies. So I think the future of cancer will be that, we have a lot of capability these days now to sequence out the genetics of cancers. But the problem is we may not have a target for it. Because if you imagine there's so many pathways, and I always say it's like a chain link of a chain link reaction. So each step along this pathway has to go wrong for a cancer to develop. And everybody may not have that same pathway that it went down to develop the cancer. So there's many roads to developing the cancer. And so that's why sometimes it's not easy to have a one-size-fit-all chemotherapy. And a lot of times what chemotherapies do is it just wipes out your whole immune system, or it just kills off non-discriminately cancer cells. So it's sort of like hoping that by killing off all cells, the cancer cells that are growing also become killed. And that's not always the case. And so, I think in the future, as we become better at targeting each person's individual cancer, we're going to find targeted therapies that work for the individual and maybe give us, as you said, better opportunities to really cure cancer.
We don't know if they'll mutate again.
Exactly. So I think, it's sort of the bacteria theory where you come up with antibiotics, but they mutate and then it's one step ahead of you. So it's this cat and mouse game that we're constantly playing. All right, so we talked a little bit briefly about it, and again, as I was saying earlier, the type of the cancer really doesn't affect the surgical treatment, because what really matters for us is what part of the pancreas is the cancer located. So we said pancreas of the exocrine part, the digestive part of it, that's the most common cancer. That's a classic when we think about pancreatic cancer. That's called adenocarcinoma, and it develops from the pancreatic duct. And that's the most common kind. The neuroendocrines are even more rare, but they're less aggressive. Partly probably, as Dr. Williamson was saying, you start getting those symptoms. If you have too much insulin or too little, then you start manifesting symptoms a little bit earlier. So we talked a little bit earlier why it's so hard to pick it up is that it's just non-discriminate symptoms. So if you had a bad GI bug, you're going to probably have half of those symptoms there, or you have diarrhea, belly pain. But I think the most classic symptom for most of us is that if someone has painless jaundice, So they develop jaundice without any belly pain. For most of us, that's probably pancreatic cancer or something along the bile duct tract, some sort of cancer there, unless otherwise proven. And so for us, that's a pretty good sign that someone may have pancreatic cancer. And so here's a picture again about why makes a difference where the location of the cancer is in relation to symptoms. We talked a little bit earlier, when Dr. Williamson was showing some of the pictures, there's two ducts. The one that's kind of coursing through the pancreas, that is the pancreatic duct. That joins up with the bile duct, which is the one that's kind of in the 11 o'clock position. Those two join together and they bring bile or digestive enzymes into the pink thing, which is the duodenum, that's the small intestine. So cancers that often grow at the head, they'll compress those ducts, and then you get the backup, and that's when you get the jaundice and other symptoms. As you can imagine on the picture on the right, if the cancer is near the tail, there's really nothing it's pushing on. And so for those, you don't end up having a lot of symptoms. Sometimes if it gets so big, it actually pushes up on the stomach. People might get nauseated or they feel full, then they may end up having symptoms. Otherwise, as you can see, a lot of the pancreatic cancers, we don't find them until they're later because they don't show up with symptoms, because they have to get to a certain size to block up structures, and that's when you have the symptoms. So we talked briefly about risk factors. So genetics plays some component, but most pancreatic cancers do not have genetics. And basically, anybody has risk for getting pancreatic cancer. And we talked a little bit about the smoking, certain races, chemical exposures, that we have found to have links to pancreatic cancer. But a lot of these are not modifiable risk, and there really isn't a lot of things that we can do to prevent cancer except for probably being healthy and not smoking. And so workup. So we talked a little bit previously about it. So things that are important, we check people's labs. If people have jaundice, their bilirubin gets elevated, people might start feeling itchy. And so, that's, Dr. Williamson talked briefly, but he mentioned putting a stent in. So sometimes when the bile duct is blocked like that and they're not, they still need workup before they get to surgery or whatever treatment, he'll put a temporary stent in. Stent is like a plastic tube that holds the duct open so it doesn't get compressed and people don't get the jaundice and their bilirubin won't keep going up. We talked earlier about the CA19-9. So the utility of tumor markers, I think for me, there's twofold. So sometimes even before surgery, if we don't see anything, we don't see that somebody has metastatic disease on CAT scan, but their tumor marker is very high, like in the thousands, then we get suspicious that they have a higher tumor burden than what we can see. Because some cancers will secrete, will cause an elevation in the CA19-9, but not all will. So that's also useful down the road. Let's say somebody's already had surgery and they've been treated. So if it was abnormal before surgery, it may come down to normal after surgery once the cancer is out. And that's something when we're surveilling a patient, we'll check the tumor marker, and at the first sign that it's going up, that may tell us, hey, the cancer might be back. And so that's useful in that regards. But as Dr. Williamson said earlier, not everybody has an elevation. So if it wasn't elevated before surgery or before the cancer is removed, then it's not really useful following it because it may not elevate even with a recurrence down the road. So we talked about CAT scans, MRIs, and endoscopy. So these are all imaging tools that help us be as accurate as we can in finding the cancer and knowing the extent. Because even with our best imaging modalities, sometimes we just can't tell for sure how much involvement there is of the blood vessels. And really the difference between resectable and non-resectable is, are these blood vessels involved? And I explained to patients that, the blood vessels can be as small as the size of a coffee stir stick, and we're trying to decide, is something touching that on a CAT scan? So we're really looking at millimeter difference in whether the cancer is involving these vessels. And sometimes, as you saw on some of those CAT scan images, it's just different shades of gray. And we're guessing based on that shading, is the cancer really close to the blood vessel? Is it actually going into it? And that's why it's so hard to tell for sure. We've gotten better as our CAT scans have gotten more accurate, but it's still not a perfect, the imaging tool we have, they're still not perfect for absolutely knowing for sure somebody resectable. So this is a little bit small, but this is just to show you a little bit about the staging system. I have some websites at the end that I listed that will have information about staging if you guys want to look more into that. But the stages I talked before start from 1 and go to 4. And so stage 1A is basically if the tumor is just within the pancreas and it's less than 2 centimeters in size with no lymph nodes involved, then it's stage 1. And the other concept that I want to let you guys know is once cancers have gone to the lymph nodes, then they have the potential to spread elsewhere. So generally for most cancers, once you have lymph nodes involved, that puts you into about a later stage 2 or an early stage 3. So that's sort of pretty standard for most cancers, is that once it's in the lymph nodes, then you're in a middle to higher stage. And then stage 1 and A and B is divided. The difference is if it's less than 2 centimeters or if it's greater than 2 centimeters. Stage 2A is if it kind of goes slightly beyond the pancreas and it's already touching, or it's going beyond the pancreas, but it's not involving the blood vessels. And then if you start getting lymph node disease, then you're going to 2B, and then by stage 3, it involves some of the major blood vessels there, then it's not resectable. So really, people beyond a stage 3 generally do not end up becoming surgical candidates. And so another important concept that I like to talk about are what are the treatment modalities. So every cancer, there really are only 3 treatment modalities. That includes chemotherapy, radiation, and surgery. I said earlier, surgery is a local treatment. It takes care of the cancer where it is, where the origin is. Same thing with radiation. That's often given as an adjunct to treatment. We give it either in the setting before surgery or after surgery. Some people, I'll talk a little bit later, they have what we call borderline resectable, where the cancer looks like it's getting really close to the blood vessels, but it's not completely involving it, and we're hoping that if we give chemo or radiation up front, we can shrink the cancer down so that now it becomes resectable. Or maybe after surgery, when we remove it, we realize they actually had lymph nodes involved, or the cancer was more aggressive or bigger than we thought, then we might give radiation to zap off any microscopic cells that might be hanging around that we don't know. And so both radiation and surgery are local treatments, and chemo is given, as I said earlier, IV, so it's a systemic treatment to prevent cancers from going elsewhere and or coming back. So we talked a little bit earlier that really surgery is the only way to cure pancreatic cancer. And the main thing that's important is what makes somebody a surgical candidate. My top 3 is location, location, location. So where is it located and what is it involving? And just even some of the basic issues. What's the health of a patient? Dr. Williamson talked a little bit about it earlier. If someone's elderly on oxygen, the operation, a Whipple procedure, which I'll talk about the components, it's probably one of the biggest operations in terms of cancer operations, and it can last sometimes 8 to 10 hours or longer. So it's a huge operation, and someone has to be physically fit to tolerate that. And not to mention the recovery period, which may take weeks up to a few months to really get back to baseline. The nutritional status, let's say someone seems healthy, but their nutritional status is poor. They're not going to heal their wounds, and they're not going to heal a lot of the connections that we have to recreate once the cancer is removed. Performance status is just how daily activities that people can do. If they're already bedbound or they're not able to do a lot, it's going to be hard for them to tolerate surgery. And other psychosocial factors. It's a big operation. You need a lot of support afterwards. If you really don't have family support or people around, sometimes it makes recovering from the surgery really hard. And so resectability. So of all the people that have pancreatic cancer, only 10 to 20% of patients actually have cancer that can be removed. So when we talk about 40,000 people have pancreatic cancer every year, only about 4,000 to 8,000 ever end up being surgical candidates. And I talked a little bit about the clearly resectable and the borderline resectable. Clearly resectable means that basically it's not involving any blood vessels or structure, so it looks like we can cleanly remove the cancer. The borderline means it might be closely involving the blood vessels, but not so much that, sometimes we can remove some of the veins, but some of the bigger arteries, we can't remove that because it's not compatible with life by removing those vessels. And complete unresectable is involving blood vessels, major blood vessels, or if the cancer has spread elsewhere. Again, at that point when it's spread, it may not be a technical reason why we can't do it, it's a benefit reason, is that we can't benefit the patient by removing the cancer since it's already spread. So another concept with resectability is, can we get negative margins? I think this is an important concept for you guys to understand, and this relates to any kind of cancer. When we remove cancer, you never want to leave any cancer cells behind, whether grossly, meaning obvious areas of cancer, or microscopic. So if you can't cleanly remove all of the cancer, you're not helping somebody. because even if you leave a few microscopic cells behind, that can grow back. I've had patients ask me, well, if the cancer is maybe 3 centimeters and you can get a good 80% of it, wouldn't that be helpful? Because there isn't a big cancer left over. And I tell them it really doesn't matter the size that's left over. It's because if you even leave a few cancer cells behind, that has the potential to come back. So really at that point, if you can't get it all out, then a patient is not resectable. And so I drew those pictures. So if the pink thing is the cancer, you don't want to cut really close to it, how I drew it with the circle there, because that means you might be leaving things behind. So anytime we do cancer operations, we want to resect it with negative margins. So the margin means the normal rim of tissue around it that is not involved by cancer. And as you saw with earlier pictures of the pancreas, it's hitting close to so many different organ structures and blood vessels. So, to be able to have negative margins of all of them, that's what makes it really tricky. And so locations of cancer. So most commonly, pancreatic cancers are at the head of the pancreas. And those are the most difficult operations. That's the Whipple operation that I'll be talking about. And then people can have cancers in the neck or body or towards the back end, the tail end. And they're less common, and those operations actually are a little bit less complicated than when they're at the head of the pancreas. And so there's different kinds of surgical procedures. And this applies to whether, the cyst that Dr. Williamson's talked about, or the neuroendocrine. So it really just is dependent on the location of what you're trying to target that will direct the operation. So there's a Whipple procedure, there's a total pancreatectomy where the whole pancreas is removed, or a distal, meaning the back end is removed. And then sometimes for the neuroendocrine tumors, if they're very small, a lot of times they're not very aggressive, you can even enucleate. It means to just shell it out. So you're not actually removing any part of the pancreas, you're just removing where that cancerous area is. So the principles of surgery that I mentioned before. So you want to resect the cancer in its entirety, not leave even a cell behind. Resecting it with a negative margin. Lymph nodes just automatically come out with the specimen. It's not drawn in the picture, but as I said before, it's like the little apples. They're basically lining everything. So when you remove a lot of the pancreas and the different organs we do, there's lymph nodes that come out with it. And then once you remove all those, you have to reestablish the digestive tract. So the Whipple procedure, that was named after Alan Whipple, who was a famous surgeon at Columbia. And he was the professor of surgery there. And it was probably described as early as 1935, but he wasn't the first person to perform it. And so what's shaded in pink is actually what is removed in the Whipple procedure. The technical name is a pancreaticoduodenectomy. We remove the pancreas, so the head of the pancreas, where that little pink thing is the tumor. You remove the duct with the pancreatic duct, the duodenum, which is that first portion of the small intestine, a little bit of that jejunum, which is the second part of the small intestine. You remove the gallbladder, you remove the bile duct, and then you remove a portion of the stomach plus or minus, and I'll go into that. So as you can see now, this is a huge operation, and there's a lot of things to reconnect back up. The mini Whipple, people think it's a smaller operation, and some of you may have heard about that. It's really not that much different. It just is that last part. If you see where the dotted line is at the end of the stomach, either you save that last little bit of stomach or you take it. So the rest of it, you're still taking all of those other organs. And so really, that doesn't even really change the time of the operation, how long the operation is. It's just you take a little bit less of the last portion of the stomach. So it's not really a smaller incision or less organs are being taken. And so this picture has a little bit of the cartoon, meaning that's the small intestine, the pancreas, and the gallbladder being removed. And so part of that is first dissecting away the pancreas, the intestines from all of those dangerous blood vessels. Then once you're done, you have to recreate and reconnect everything. So we have to connect, since we took the pancreas, we have to have a way for the pancreatic duct and juices to come back into the intestines. We have to have the bile duct, because we took that also. We have to have the bile drain back into the intestine. And then we have to make sure when you eat, your intestines are recreated. So the small intestine has to be reattached to the stomach. And so if you see in the picture on the left side, that's a picture of the mini Whipple. You still see that the pancreas is floating where it's sewn into the small intestine. The green thing on around 11 o'clock is where the bile duct's connected back into the small intestine. And then the last connection in this picture, when they didn't take the stomach, the first part of the small intestine connected into another part of the small intestine. And on the right, you just see some of the stomach taken away. So that's the difference between a mini Whipple and a full Whipple. In a total pancreatectomy, pretty similar as well. So the only difference now is you're taking the whole pancreas. You don't leave any of that behind. Whereas earlier we kind of cut it in the middle of the pancreas and you preserve some of that. The difference in that is that for patients after surgery, then they're committed to lifelong pancreatic enzymes, insulin, because now they don't have any way to digest food, whether with hormones or digestive enzymes, because their body's no longer producing it. Same thing, you just have to reestablish bile flow and flow of the intestinal tract. So the only difference here is that you don't reconnect the pancreas back up to the intestine because the remaining pancreas is gone. So it's still a big operation as well. And that's probably commonly used for cancers that might be in the center part of the pancreas. So if you need margins to get it clear, it's too close to the head and the small intestine, and it's involving a good portion of the pancreas. That may be why somebody needs a total pancreatectomy. A distal pancreatectomy, that's probably of all the operations, that's the less complex operation, and that nothing has to be reconnected. So if you've seen the picture, the tail of it's taken, and then the spleen, because the spleen basically hugs the tail of the pancreas. So those two organs are taken, but we didn't have to take any of the bile duct, we didn't have to disconnect the intestines, so there's nothing to reconnect. And so that probably, of all the operations, is the shortest and the less complex. So what happens after a Whipple? So, when I talk to patients, I really try to set them up for the recovery process because it is really a big operation. After surgery, most people are in the hospital for at least a week to 10 days. Initially, they have drains in their nose, in the stomach, in their belly. So there's really a lot going on, and all these connections have to heal. And so we talked a little bit earlier about doing it at high volume centers. So traditionally, the mortality rate was really high, but now at places that do it often, less than 5% of the patients actually die from the operation. But you still have complications. It may not be related to the operation. People can get a heart attack, they can have a stroke, they can have pneumonia. These are unrelated to the operation, or any of those connections I talked about, those 3 connections, any of them can leak. The pancreatic duct is probably only a few millimeters in size. So you can imagine sewing something that tiny. I say it's probably like the size of a spaghetti. So something that small that we're connecting into the intestine, it can very easily leak. And so these have to heal, and then everything has to heal before someone can eat. So a lot of times they're not eating for about 4 or 5 days after surgery, then their nutritional status isn't great. We do big incisions to get in there, and so recovering from that. So as you can imagine, it's a lengthy recovery period. And sometimes the pancreas doesn't kick in right away. So you have to give them pancreatic enzymes to supplement when they're eating. You might have to give them some insulin also because that hasn't kicked in. Also, other issues after surgery, any of those connections can narrow, because once things scar down, that opening closes. So something that's so small already can close up, and then you have what we call a stricture or narrowing. You can have bowel obstruction. Anytime you have surgery, your body creates scar tissue, and that can cause the bowels to get obstructed. And then a lot of people, because we take a portion of the stomach, have to change their eating habits. So they have to take smaller, more frequent meals because they might get full more easily. In the last few slides, I kind of want to reiterate about survival. And so, when we talk about overall 5-year survival rate, we were talking earlier, it's really, pretty poor in that it's maybe 6%. That's for all comers, whether they're treated or not treated, whatever stage they are in. For patients that are completely resected, the survival rate can increase. So we say most people with early stage 1 probably, and so cancer statistics are always given as what's the survival in 5 years, how many people are still alive after 5 years. It still is only maybe up to 25% or a little bit greater are alive after 5 years. And that's in contrast to something like breast cancer. If something's early, probably at 5 years, 95 to 100% of the people are still alive after 5 years. So pancreatic cancer is a very aggressive cancer, and the average survival is less between 1 to 2 years for people that get diagnosed. This is something by 5 years. So when we talk about on the far left, localized means it's just confined to the pancreas. If it's regional, it may have gone into the lymph nodes, and then if it's distant, it's spread elsewhere. So in 5 years, about 25% of the people are alive if they have very early localized disease. Once it's gone to lymph nodes or other areas, then rates are down to 9% in 5 years. And then if it's spread elsewhere, really 98% of the people are not alive after 5 years. And so I talked a little bit earlier about chemotherapy. It can be given before or after surgery, and it's an adjunct. A lot of times when people have the lymph nodes involved, then they're going to get chemotherapy, because now once it's in the lymph nodes, it has the potential to get elsewhere. Or when I talked about that borderline, they're kind of close, the vessels might be involved, we might use it before surgery to shrink things down, so then we have a better chance to have things fully removed. Also, it can help, might be used when people get radiation. It helps to sensitize the radiation and make the radiation more effective. And finally, when people can't be operated on, their only option for treatment may be chemotherapy and or radiation therapy. So I said radiation therapy is given where a radiation oncologist will plan a patient, they'll do CAT scans to evaluate the tumor, and they give radiation beams. And it's a quick treatment. It's about maybe a 10 or 15 minute treatment where they target radiation beams at the cancer to hopefully help shrink it down. And it can be used in the palliative setting where if people have a lot of pain, or it can be used, in an adjunct to surgery. Once it's removed, we want to make sure things don't come back, then they get radiation treatment. The other thing that I didn't mention earlier is that, when Dr. Williams talked about, our ability to decide if someone is operable or not, and we open somebody up, they have all this cancer. So these days, when we plan for a surgery, we always start with a diagnostic laparoscopy. That basically is putting a camera inside the belly, and we actually look around. Because if you can imagine, if someone had probably a sesame seed sized deposit of cancer, you're not going to be able to see that on the CAT scan. So that's why the CAT scans, can't predict fully if someone have these tiny little droplets of cancer. And so we put a camera in, we look around. Do we see anything over the liver? Do we see anything in the belly lining? Look around. If there's no cancer, then we make the bigger incision and plan on doing the operation. And then the next step, I tell people there's 2 steps where we might actually stop the operation. So once you pass that, then the next step is we sort of move all those organs out of the way. So moving the stomach out of the way, moving the colon, and then we get to the pancreas. Then we see, is it too stuck or wrapped around and involving the blood vessels? Sometimes you can't tell that perfectly on the CAT scan. You can get a good guess, but you don't know for sure until you're really there. So before we commit somebody to the operation, we actually go look and feel around the vessels. If it's involving that, then we stop. So, you may not end up getting a big operation if we know ahead of time, and we kind of go through each step to prevent somebody from having this big operation if we can't fully remove the cancer. And so there are different little steps to stop points when we do the operation. And finally, a few words about clinical trials. So a lot of places offer clinical trials. They're used a lot in cancer care, and I think they're an important part of cancer care. It helps us develop new therapies. So clinical trials can be in a few different settings. So it can be in the setting of trying new drugs to see if they work, and they compare things that work to new drugs that are developed to see which one works better. It can be used to test different regimens and combinations. Sometimes we find one drug works and another drug works, and we say, well, if we combine these together, maybe they work better, and they don't always. And then finally, clinical trial can also involve just keeping specimens, kind of what Dr. Williamson was talking about earlier when they were keeping the cyst specimens. So we can keep cancer specimens and then do evaluation of them and then use that to hopefully help patients down the road. So I think that's an important part for patients that have cancer, is being involved in clinical trials, because it helps to not only benefit people down the road, it may benefit them as well. And so my last 2 slides, the bottom line, really what I wanted to emphasize today is that pancreatic cancer is very rare, but it's a very hard cancer to treat and a very aggressive cancer. And it kind of makes sense based on the location and what's involved in the area. And really, the best approach is a multidisciplinary approach. It's getting all the specialists, getting all the brains together, and tailoring that therapy so that we can do the best in terms of targeting the cancer. So the last slide that I put up are some resources that I think are helpful. So I try to tell people, good places to go to. And I don't have the Ron Foley website up, but that's a great place as well. It's important to get your information from good resources, because a lot of people can put up web pages and their situation may be different from yours or people that you know. So you don't want to just go to any website and get information, because there could be a lot of wrong information out there. So the best websites that I found, and I direct people towards, number 1 is the NCI, that's the National Cancer Institute. That's the government's website, and a lot of the major clinical trials are sponsored by them, and they have great information for all kinds of cancer types. The NCCN, a lot of people don't know about this particular organization, but they're an alliance of the top cancer centers, and they publish a guideline on just about every cancer type. And any physician that works with cancer uses these guidelines. So those guidelines help us say, how do we work people up? Does everybody get a CAT scan? Do people need PET scans? What do we do? And once it's diagnosed, how do we treat it? And do they get chemo? Should they have surgery? And even after surgery, how do we keep an eye on them? Do we see them every 3 months, every 6 months? Do we get CAT scans? So they have guidelines that physicians use, but they also have great information for patients. And lastly, the American Cancer Society, they're very well known, they're a nonprofit, and they have very good information on staging and other information related to cancer.